Good morning. Thank you for the kind introduction. So we are on day 2, and the theme's changing. Diagnosis, epidemiology, surveillance, and we heard very good lectures yesterday on vaccination and immunology and pathogenesis of flu. So we're going to kickstart today with the clinical diagnosis of influenza. And as was presented, my background, I'm a clinical microbiologist, and I direct the clinical microbiology lab at Children's Mercy Hospital in Kansas City. It's a freestanding nonprofit organization in Kansas City, and we have about 350 beds in the hospital, and we do testing for various infectious disease in the clinical microbiology lab. And certainly, flu is one of the top infectious disease diagnoses that we deal with on a yearly basis as we see the epidemics during the winter time. So the objectives of my talk today are going to be to give you a broad overview of the landscape of current laboratory diagnostic testing available for us for influenza, and more specifically, provide you an idea of the strengths and weaknesses of these methods, the traditional methods, and the more recent molecular laboratory tests, and to discuss a recent FDA ruling on the rapid antigen test, one of the most popular influenza diagnostic tests that's currently used in the infectious disease testing, and then give you some idea of the potential clinical impact of rapid molecular testing for flu, as the field is moving towards more molecular diagnosis. So by way of introduction, as you all know, respiratory viral illness is one of the most common infection in children and adults, and it is the second leading cause of mortality in the world, and clearly a major cause of morbidity in U.S. and the developed part of the world. And influenza and RSV cause seasonal outbreaks, and early diagnosis clearly improves care. There are a lot of studies that show that early and rapid diagnosis helps in patient management and outcomes. Now, there's on the other side of the spectrum, we clearly have non-influenza respiratory illness, or ILI, and they also are a major burden, and it's estimated at about 500 million infections per year, and the economic impact of which is huge, about 40 billion per year. So, and one of the major problems with respiratory infection per se in terms of diagnosis and treatment is the rapidity at which we do things. The results need to be available rapidly so the physicians can choose the right treatment. So what happens is the currently available tests are either insensitive or do not provide rapid results, as a result of which physicians choose to treat many of these patients with antibiotics. And as we all know, the vast majority of respiratory illness are caused by viruses. So many of these antibiotics are unnecessarily used. So as you can see, greater than 70% treatment in the outpatient setting is unnecessary, and clearly in the inpatient setting too, nearly 50% of antibiotics are unnecessarily prescribed. And it doesn't stop there. We have nearly about 142,000 emergency room visits due to antibiotic-related adverse events. So it is imperative that we do a good job in rapid diagnosis of respiratory illness. So a bit of a background on influenza epidemics. I'm pretty sure the audience here are well versed about it, but just we have a broad idea of the epidemics. Member of the Orthomyxoviridae, influenza type A and B are the major causes of epidemics in humans. Transmission via large particle droplets, incubation about few days. Every year in the United States alone, 5 to 20% of the population gets the flu infection. More than 200,000 people are hospitalized, and about 36,000 people die from flu-related causes. Now, in shedding, it's usually in adults, it's thought to be about 5 to 10 days because they have good immune system and they do control the virus. On the other hand, the children tend to excrete this virus for a longer time period, greater than 10 days, and immunocompromised patient population for weeks and months, they excrete these viruses. Now, when you look at take a closer look at the children, especially in 0 to 4 years of age, the average is about 100 per 100,000 children without any underlying medical conditions get influenza infection. On the other hand, if they have other high-risk medical conditions such as asthma, diabetes, chronic lung disease, etc., then the number goes up 5 times more illness in this patient population. And interestingly, it seems the highest among infection rates seems to be in children 0 to 1 years, and this compares well with the elderly, greater than 65 years. So signs or abrupt onset of constitutional respiratory signs such as fever, myalgia, headache, sore throat, and cough. And hospitalization usually ends up being about 4 to 11% intensive care unit, and many of them need mechanical ventilation. And the complications, certainly otitis media, bacterial pneumonia is a very well-known complication of influenza illness. And deaths are usually associated with bacterial complications associated with influenza infection. Encephalitis, encephalopathy, and myocarditis and myositis are less well-known complications, but they do occur, and it seems to be strain-dependent. So one would think that some of these clinical symptoms are straightforward for diagnosis, and a laboratory test is not needed. And for the most part, the answer is yes. It seems reasonably well. The clinicians do a good job of clinical diagnosis just based on signs and symptoms. However, in the adults and based on some of the different influenza strains that circulate, this is not the case. So clearly, we need good diagnostic tests. So yesterday, we heard some great talks on the prophylaxis, the vaccines that are being developed, and so there are some promising candidates, and we already have many in use. And then we also heard some great talks on treatment and the options for neuraminidase inhibitors and so on and so forth. So today we will look at the diagnosis aspects and epidemiology and surveillance. So clearly, when your yearly epidemics happen, the prophylaxis, if there is a good match, you have a good year, the virus is well controlled. If you don't, you deal with a lot of patient population that needs to be diagnosed on a timely fashion. So when you consider diagnosis, there are 2 key aspects. One is the epidemiology infection. Everyone's well versed with this bell-shaped curve, and you could see that you take that into account to understand the epidemic of the influenza in your geographical region, and you also do some laboratory testing to diagnose the illness. So looking at some of the traditional methods that were available, influenza culture. So the tube cultures, primary monkey kidney or the MDCK, or good cell lines or the mink lungs are also pretty good for culturing the influenza virus. Now, these tube cultures take a long time to grow these viruses, up to a week or more. And so with the rapid diagnosis, they do not fit well with the current needs of the clinician that faces the patient in an outpatient setting. So slowly, these tube cultures are phased out, and now we have these shell vial systems. These are tubes with cells grown on a cover slip. The virus is infected, and within a day or 2, you detect the virus with fluorescent antibodies. So these shell vials are called co-cultured cells, and they seem to synergistically improve the yield of the virus or the detection rapidity. So the R mix, which is a mixture of A549 plus mink lung, and then there is the R mix 2, which is the A549 plus MDCK cells, both seem to improve the detection rate and the speed at which you can diagnose these infections. So most of the viral illness are detected by day 1 with this fluorescent antibody, and you stop the entire process at day 2. So you can see how significantly we've improved from a week to 10 days to all the way down to 1 to 2 days. Now here are some studies that show that these rapid shell vials perform as good as the culture, about 99% sensitivity for flu A and 95% for flu B. Now, there are also cryopreserved that can be used on demand. So you could get these shell vials, freeze them, and pull them out of the freezer as you need them. And they too have very good sensitivity and performance criteria. Now, these are options for small volume laboratories, and still the diagnosis is in days and not in hours. So the next traditional methodology is the DFA, where you could do this testing directly from the patient's sample, from a respiratory swab or a respiratory aspirate. And DFA is a highly sensitive and a specific test. However, you need a virologist who are well trained and have a lot of experience with this methodology, because there's a lot of background training. And so it is a laborious method, and turnaround time takes few hours. Now, the sensitivity of this method is clearly affected by the quality of the swab or the quality of the sample. Flocked swabs provide usually good recovery, and I'll show you how a flock swab looks in few slides, in the future slides. And now again, this technology is limited to 7 respiratory viruses, the most common ones being influenza A, B, RSV, parainfluenza 1, 2, 3, and adenovirus. And more recently, they've added the human metapneumovirus to the mix. So usually, you spin down the respiratory specimen and you cytocentrifuge it, and then you add the antibodies for pan-respiratory virus to detect if there is any respiratory virus in your sample. And if you do see a positive signal, then come back and type it for the individual one of the 7 viruses. So, as I just mentioned, we've come from days to hours, but again, in a busy ED department in an outpatient setting where the patients are already waiting for several hours, you need a test that can provide results within minutes. And that is where these rapid antigen tests fits the need of the clinical laboratory. These rapid antigen tests are, for the most part, have good moderate sensitivity for seasonal flu A/B. However, in the most recent experience with the pandemic H1N1, these tests were totally useless. And I'll show you some example of our own experience with these tests. But however, on the other hand, their specificity is pretty good, greater than 90% for most of the time. Now, so the benefit of rapid antigen testing in the outpatient setting is patients can be triaged appropriately, infection control measures can be instituted if they were positive, reduced antibiotic usage, which I already mentioned was a major problem in this outpatient and inpatient setting, timely antiviral treatment once you know they are positive, reduce unnecessary diagnostic workups because you already know the diagnosis, and overall reduction in medical care costs. There are numerous publications in the literature that describe each of these benefits from rapid antigen tests. So here's an example of how these tests look. Very simple. You put a drop of a sample in both of these wells, and the virus-infected specimen migrates through those lateral flow cartridges. And here is your control line, and here is your test line. And if there is a positive, so control is positive, internal control for the assay, and your test is positive, so this is a flu A positive sample. Now, it looks simple, but it is really not that simple when it comes to the performance of these assays. There are various factors that influence the performance of this assay. So here are some examples. Host factors: age of the patient, duration of illness, specimen type, specimen transport. So children usually excrete high viral loads. They're considered the factories of respiratory transmission. And so they excrete viral loads up to 10 to the power of 4 to 10 to the power of 6 plaque-forming units per ml. And so these tests perform pretty well in children, but not so in adults, who usually tend to excrete virus at a much lower level. Duration of illness. These tests perform well if you test the specimens within 3 days of onset of illness. And as you can imagine, many of the patients do not show up within 3 days, and usually they come when they're really sick, and these tests don't perform at that time point. Specimen types: there are different specimens that you could collect from the patient: aspirates, washes, swabs, mid-turbinate swabs, and each of these specimen type have a different performance criteria when it comes to these kits. And the transport medium is also very important. Viruses are labile, so you clearly need a viral transport medium, and rapid transport to the lab improves yield. So here are again the several specimen types that you could use. And now nasopharyngeal aspirates on washes for the most part are good, but it is cumbersome to do this procedure in an outpatient setting. And mucus that comes along with this collection method interferes with some of these assays. So cell quantity may vary between collection, and it is suitable for PCR and culture, but not so suitable for EAA and DFA method. Now, for the most part, these cumbersome methods, specimen collection method, are replaced by these easier methods such as NP swab, nasopharyngeal swab, throat swab, or a mid-turbinate swabs. Now, I'll show you an example of a flock swab in the next few slides. And these are, again, a latest invention that has improved the collection of the sample. And they collect more cells, less mucus, and they are suitable for DFA, and they're also suitable for most of the other tests. So here is the flock swab. This is, again, a very good technology where the shaft is sprayed with nylon fibers in a perpendicular fashion compared to the usual woven swabs. As such, the cellular material in the nasopharyngeal area gets trapped between these fibers, and then they elute easily into the viral transport medium. So they have a high surface area, collect more samples, and rapidly release these material back into the viral transport media. So here are some studies that show that the nasopharyngeal swab are as good as the nasopharyngeal aspirates, about 98% correlation. Now, when it comes to, here's another poster that shows the mid-turbinate swab is as good as the nasopharyngeal swab. And here is one of our own studies that shows that the mid-turbinate swabs is as good as a nasopharyngeal aspirate, which I mentioned earlier is a bit cumbersome to collect, especially with the patient, with children in our hospital setting. So the other factors that influence the performance of these tests, the influenza activity in the area and the viral subtype. I'm pretty sure most of you are very familiar with these basic terms, but pretty quickly so that we are all on the same page here. Sensitivity, some of the definition, sensitivity is the proportion of actual positives to which correctly are identified as such. Specificity is proportion of negatives which are correctly identified as such. These are some of the criteria that we use in evaluation of a test. And the positive predicted value or negative predicted value usually take the pretest probability or the clinical information in hand, and that tells you the proportion of patients with a positive result or the likelihood that they are correctly diagnosed as positive, and the proportion of patients with negative test results who are correctly diagnosed as negative. So with that in mind, let's take a flu test. Now, it's rare to find a rapid antigen test with a 95% sensitivity, but even though let's assume that there is one such test with a 95% sensitivity and 96% specificity. So for the most part, this is a very good test. Now, if there is a prevalence of only 1% flu, which happens early in the season, as you remember the bell-shaped curve. Now, if you have 2,000 patients that you test, that equates to about 20 patients that are positive for this are infected. Now, you have a 95% sensitive test, you're going to detect the 19 out of 20, so that's pretty good. Now, on the other hand, you have 96% specificity, so you still are detecting 80 as positive when they really are not infected. So when you look at the positive predicted value of this test, when the season is so weak, is really bad. So really, only 1 out of every 5 positive test result means infected patient. So it is very important to keep this in mind, as a result of which, when we offer these tests, we do this only during the outbreak. Rest of the year, they do not get a rapid antigen test. It's only a culture or a PCR, which tests are called confirmatory tests. So these screening tests are offered only during the epidemic, when the season of influenza starts in our laboratory. So on the other hand, when you look at a 20% prevalence, which you see towards the peak of influenza, then the positive predicted value improves of the same test. So again, this goes to show that one needs to keep the activity of the influenza in mind as you roll these tests out for clinical testing. So here is an experience of our laboratory testing when the 2009 pandemic influenza outbreak happened. So the previous year, 2008-9, we had our regular season. The season started in February of 2009 and then ended at about April, which was the regular flu season. And we had the rapid antigen test and the respiratory viral panel PCR. And pretty quickly, the first case of our pandemic H1N1 patient was seen in April 27 of 2009. And we offered both of these tests, but within the 2 weeks, we realized that the rapid antigen test was not performing well. In our hands, it was only 30% sensitive at that time point. So we stopped offering rapid antigen test and only made respiratory viral panel, which is a multiplex PCR and pretty cumbersome to do in the laboratory because it's a batch mode testing. We still offered only the respiratory viral panel PCR, and the rest of the season went along fine. But later, we had to develop a real-time PCR so we could take care of the next wave, or the second wave, if you will, for the influenza that happened in the same year. So if you see here, August through December of that year, we had the second bigger wave, or the bigger peak of 2009 H1N1. So the ProFlu PCR was implemented. And then within a few weeks later, this was an expensive test. We developed our own laboratory-developed flu PCR AB. So you could appreciate this again from the industry. You have time to work on these vaccines again on a yearly basis. And in a clinical laboratory setting, if you want to do a good job of detecting these viruses, you have several weeks or months to quickly adapt to these changing viruses and bring in these tests. So this caught our attention and my attention, and so I thought I will do a survey of laboratory practices in U.S. So I sent out a survey to all the hospitals in U.S., and many of them responded. And as you can see, if there's nonprofit organization, hospital network, community hospital, academic institutions, these are the groups of hospital systems that responded. So interestingly, when I asked them several questions about the rapid antigen test before pandemic H1N1 and post, so as I mentioned earlier, these are the most popular tests in the outpatient setting. And although academic institutions don't use very much of them, but all of the hospital laboratories pretty quickly realized how poorly these assays performed in the post-pandemic H1, and many of them dropped these tests, and they moved towards molecular testing. And now you could see some of the nonprofit organizations, which we are, and this is our lab, which we quickly switched to the PCR. But there are majority of the community hospitals, they know these tests don't work, but they still kept using this because they did not have the means to develop new laboratory tests or look into the other options that were available. So here is a graph of the influenza testing over the years in our laboratory. This is based on rapid antigen tests. And you would see some of these years that are heavy season, and this is 2014-15. And usually when the flu comes, the epidemic in our area is about 3 to 4 months. Here you could see it's really last year season was more like 5 months, and the explanation is right here. The influenza vaccine was only 18% effective for flu A strains and only 45% effective for flu B strains. As a result of which, we saw a huge wave of influenza A followed by influenza B, which is pretty typical for the epidemic. And so these are the increased number. We ended up testing about 10,000 patients during this outbreak last year. So the other factors are analytical factors or test characteristics and result interpretation. These are subjective results. As you can see, one has to glance hard at these cartridges to see if there is a weak line or not. And so there are some subjective biases that can be introduced in the result interpretation. And obviously, these rapid test results, the results are available within 15 minutes, but one has to report it actively to the clinician. So now the newer generation of the rapid antigen tests, such as this objective reads, where the instrument basically reads the line for you using computerized algorithms. And this is based on chemiluminescence method, and here these two assays are based on fluorescence antibodies. So these have removed the subjectivity, and as such, they have also improved the performance of the assay. So if you look at this comparator study that we did, here is a subjective assay, the Binax, now compared with this objective read, which uses an instrument to read the results. And you can see there's nearly about 20-point increase in the sensitivity of these assays when we use the objective reads. Here's another study by a different group. Again, the message is similar. When you look at the subjective reads, about 80% and another 15% gain in sensitivity when you use these objective reads. Now, one caution though, when you look at this method, which is the Sophia method, you see the positive predicted value is low, mainly because there were false positives, both for flu A and flu B, noted during the season when they performed this test. And that was attributed to the fluorescent technology that was used in that chemistry. So a history about this rapid influenza diagnostic test. It was approved as early as 1998, and there were about 18 tests that were available. For the most part, they had good performance criteria, and about 73% sensitivity for flu and flu A and 60% for flu B. But then if you look at the same kit from manufacturer 1, their package insert states 79% sensitivity, lower bound of confidence interval 75, higher bound on 83, and all the subsequent studies, clinical studies that were done after the marketing of those tests, and you could see all these yellows marked studies basically did not perform to their package insert. So FDA has come out with a ruling, and it's very good they did that. Just happened last year. Now, they reclassified the rapid antigen test to category 2 device, which means that these tests needs to be evaluated on a yearly basis, and the point estimate need to be at about 90% if these antigen tests are compared with viral culture for flu A, 80% for flu B. And if the manufacturer chooses to use a molecular method as a reference method, then the performance need to be at 80%. And they also added additional controls on post-marketing surveillance, such that when these assays are rolled out in the clinical, for clinical testing, the manufacturers are required to do annual analytical testing of their device with contemporary strains that are circulating during the season. And they're also supposed to do standardized panel testing on a yearly basis with strains distributed by FDA or CDC. And they're also supposed to test the performance of their assays with kits that are available for the newly emergent virus. So the diagnostic challenge is lack of a rapid and highly sensitive method for influenza and point of care setting. So the impact is, as I mentioned earlier, there is improper use of, if you do not have a good test, you have improper use of antivirals, overuse of antibiotics, additional diagnostic workup, and increased cost, improper infection control, overall increase in healthcare costs. So the solution is a molecular test in the point of care setting. So rapid antigen tests, these are the molecular tests that are currently available in the market. So I'm almost running out of time, so I'm just going to quickly run through those molecular tests. These are point of care tests. These are the two ones that were approved in the last 2 years, and they perform really well compared to culture. You could see at 99%, 100% sensitivity compared to culture, flu A and flu B. Now, when you compare this rapid point of care test, molecular test, which is isothermal amplification, 15 minutes, then you have about 90% sensitivity compared to a real-time PCR. Again, very good performance. And you could see that the positives compared to a full-blown PCR are here, and some of the weak positives by PCR are missed by the isothermal amplification assay. Here is another isothermal amplification assay, which was compared to another real-time PCR, very similar results, about 90%. And here are multiplex respiratory panel PCR assays that are out there, and they are becoming more popular. You could see that in our CAP, College of American Pathologists proficiency testing, these are the various assays that are becoming popular in the clinical laboratory. And They provide additional results for us to look at the various strains. So the multiplex PCR will give us strain identification, so we can use that in antiviral therapy. And some of the disadvantages is cost, reimbursement issues, and because it's multiplexed, there is competition between the analytes, and we could miss some of these assays. So the summary, rapid antigen tests are useful for outpatient management. Antigenic drift and shift in influenza strain clearly influences test performance. Specimen collection method is a key component to the performance of these tests. QC monitors need to be in place and reviewed periodically, and confirmation tests are needed when antigen tests are used. The newly developed rapid molecular assays have promise, and shell vial culture can still be used with results available in days. Multiplex PCRs are becoming more popular and help us with detection of both the flu and influenza-like illness on the other respiratory virus, and epidemiological data are helpful in treatment. Thank you for your attention.
Questions, please? Comments? No questions? Yeah, there's one there.
Sort of a comment and a question. I mean, from a clinical point of view, it's so much more useful to have a test which you can do, which will also detect RSV, coronavirus, adenovirus, et cetera, et cetera. So where are we with this kind of technology right now? You know, do we have something which is likely to come on stream soon that, you know, as a physician in an emergency room, you can run off a test and an hour later you'll know if your patient's got whichever virus?
Yeah, so these are the tests that I kind of ran through the slides. So these are the multiplex PCR assays. So if you look at this, so this, among all of these tests, this is the sample to answer type of methodology that can test for 20 different viruses and bacteria. So it includes the entire array of flu, the subtypes of flu A, flu B, RSV, human metapneumovirus, parainfluenza 1, 2, 3, 4, adenovirus, coronavirus, rhinovirus, and mycoplasma, chlamydia, and Bordetella pertussis. So all 20 different pathogens detected within 1 hour. Takes about a minute or two to do the testing, to set up the assay, and 1 hour later you can detect. And so that's the perfect example for what you're asking for, a rapid turnaround time. Now, these are the other options if you're to do batch mode analysis. So here you can look for 14 different viruses. Here you can look for about 12 different viruses, and here's another one for 7 different viruses. So there are several of these FDA-cleared assays that are in the market right now, and certainly, as I showed one slide about the College of American Pathologists proficiency testing, these assays are becoming more popular because of their wider detection of all respiratory viruses.